Hello, everyone. Thanks for tuning in. In today's Greatest Hits series, we call back to some key fundamental concepts to help you ace that NCLEX. Let's start out with a question drill from Nursing Coley that refreshes our nursing fundamental concepts. Enjoy.
The nurse is caring for a client who requires neutropenic precautions. Which of the following actions should the nurse take? Select all that apply. I will give you all about 30 seconds. Option 1, request a prescription for the intranasal influenza vaccine for the client. Option 2, place a surgical mask on the client during transport. Option 3, remove fresh flowers from the client's room. 4, assign the client to a private room. Or option 5, instruct the client to bathe daily. Which one should we be choosing? Like always, make sure you share, follow. We had a lot of new followers this past week, and we love to see all the new faces here. But share it to all your friends and other nursing members that are about to get ready for their NCLEX. We are a great community, and we're welcoming all new members, and so excited to have you guys here. So let's get to the answer for our first question. Pretty much all of them, except option 1, options 2, 3, 4, and 5. So with this, we want to know what is neutropenic precautions. Neutropenic precautions are precautions that we give to patients that are experiencing neutropenia. And neutropenia is when their neutrophils, or the white blood cells, go below a certain level, usually 0.1. And the white blood cells are very important because they are the ones that fight the infection. So if they are not having those blood cells to fight the infections, they get infected and they get sick very easily, and they can get sick very bad. So we want to have them in a certain clean environment to prevent them from getting any infections. So we're looking for answer choices that will help promote these clean and pretty much infection prevention environment. So options 2, 3, 4, and 5, placing a surgical mask during transport just because we want to protect them from inhaling or droplets coming on them while they're going their day-to-day lives and outside their clean environment rooms. Fresh flowers in the client's room. I know this is a big discussion in hospitals because your loved ones bring you the flowers and you want to see them, but these flowers can harbor bacteria, so we don't want to put them in the environment. Assign the client to a private room. Yes, we want them to have their own little environment, their own clean room, and we want to instruct them to bathe daily, okay? Let's be clean, have clean bodies. The reason number 1 is not a correct answer is because we never want to give a live vaccine to a patient that is immunocompromised because they're already having a problem to defend and fight infection. So we don't want to give them a virus. So that would be the incorrect answer. So good job, guys. I saw pretty much everyone give the right answer, so good job. Let's move on to question 2. The nurse is planning care for a client who has an indwelling urinary catheter. Which of the following interventions should the nurse include in the client's plan of care? We'll do about 35 seconds. Apply tension when securing the catheter tubing to the client's inner thigh. Maintain the urinary drainage bag above the level of the client's bladder. 3, empty the client's urinary drainage bag when it's completely full. And option 4, clean the client's perineal area with soap and water. Let us know what you guys think. Which is your answers? We got a lot of good answers. Good job, guys. Also, let us know if you have recently passed the NCLEX. Anybody taken the NCLEX recently, or have you scheduled your appointment for the NCLEX? We are here to wish you the best of luck. I know it's a little nerve-wracking when you actually set that date, but we're here to cheer you on. So let us know if you scheduled yourself for the NCLEX. Ooh, Miranda just passed. Good job. Congratulations. Welcome to the nursing world. And then lots of good answers. So good job, guys. Correct answer for this one is option 4. Cleanse the client's perineal area with soap and water. We're looking for the intervention that is correct and that is safe and appropriate, and that is option 4 in this case. Option 1, we never want to apply tension to the tubing. Obviously, that is very painful, so we want to always give a little slack, but we do want to secure it on the inner thigh, but never apply tension. Option 2 is incorrect because we never want to place the bag above the client's bladder. We want gravity to help us in this case, so we want to place it below the bladder so the flow can go downwards and away from the patient. Option 3, empty the client's urinary drainage bag when it is completely full. We want to do this before. We don't want it to actually get all the way full because it can cause backflow and back to the patient and cause infections and stuff. So always empty it, probably less than 1/2, so 1/3 to 1/2 full. It would be the correct option. So let's move on to question number 3. The nurse is screening clients for those at risk for developing pressure injuries. The nurse should recognize the client at highest risk for developing a pressure injury is the client who ... Let us know what you guys think in the chat. Put your answer choices. And let's go. Good job. Oh, and thank you guys for sharing and liking it. I see some people said that they shared it with their friends. Good job. Thanks. We really appreciate the community getting bigger and better every day. We want to know which is the client at the highest risk for developing a pressure injury. So that would be, drumroll, option 1. Option 1, these clients that frequently slide down in the bed are at the highest risk for skin breakdown because that friction and that shearing causes constant pressure on the skin and promotes a pressure injury. So that would be the correct answer. All the other options, options 2, 3, and 4, these indirectly can maybe cause a pressure injury. If they're constipated, they're maybe not mobilizing as well, so they might be, but not moving as much, but we don't know fully with that case. Same with the indwelling urinary catheter. They might be not getting up to go to the bathroom as much. So it could, but not necessarily in this case with all the information that we have. The only one that is right out is option 1 with the frequently sliding down in bed. And obviously option 4, if they're walking around, they're probably the least likely to get a pressure ulcer. So good job, option number 4. Moving on to question number 4. The nurse is talking with a client who has a colostomy. Which of the following statements by the client would require follow-up? Drop your answers in the chat. I'll give you about 30 seconds. Option 1, I should avoid drinking coffee and alcoholic beverages. Option 2, I need to chew my food completely before swallowing. Option 3, I can continue to swim in the pool every morning. And option 4, I will wait until my pouch is full before emptying. Which one would require follow-up? Let us know. Lots of good answers in the chat. Did anyone join us on Tuesday for our lecture? Every week we have lectures on Tuesdays and question drill sets on Wednesdays and Thursdays with varying topics. So make sure to stay in or tune in every week. Different topics, different things to get new information about. And we always love new topics. So if you want to drop in some information of what topics that you would like us to cover, let us know in the chat as well. Oh, see, Nello, I love the lectures. Thanks for tuning in. Okay, let's go to the answer choice. Option 4 is the correct answer. I will wait until my pouch is full before emptying. So with this question, we are looking up for what do we need to follow up. So what is the nurse doing wrong or teaching wrong so we can follow up and give the correct option. So we don't want to wait until pouch is full. What a colostomy is, it is a surgical intervention that brings the colon out through the abdominal wall, and then the stoma sits on the outside, and we put a plastic covering or an ostomy bag over the stoma to catch any feces and gas that comes out, since it's not going out through the rectum. And if that pouch becomes full, it is more likely to leak and spill, or it can start detaching from the client's body. So we want to make sure we empty it a lot sooner so we don't have any of those problems happening. All the other options 1, 2, and 3, these are good teaching points that we do want to encourage for our clients. They should avoid drinking coffee and alcoholic beverages, just in case that induces diarrhea. If they have diarrhea, that's a lot of emptying of the bag, which can be kind of not fun. Chewing the food completely before swallowing. This is very important because it doesn't get to go through the entire colon with the digestion. So we want to make sure that when it does get down to the colon in the small part that it is going to empty out in the stoma in an adequate way and not form a blockage. And then option 3, continue to swim in the pool. We want to encourage the same lifestyle that they had before, so the pouch can get wet, just to keep an eye on it in case the adhesive or anything starts peeling away, but they can still get the pouch wet with showers and with swimming. So option 4 is the correct answer in this case. Next question. The nurse is observing a staff member administer eye drops. Which of the following actions by a staff member would require the nurse to intervene? I'll do 45 seconds because these answer choices are a little bit longer. Option 1, position the client in the supine position before administering eye drops. Option 2, clean the client's eye from the outer canthus to the inner canthus before administering eye drops. Option 3, gently pull down on the conjunctival sac with the non-dominant hand and instill the eye drops with the dominant hand. Or option 4, repeat eye drop administration if the client blinks and the medication lands on the outer lid. So, which would require the nurse to intervene? Like always, a shameless plug, but we have a free trial on our website at uworldnursing.com that has obviously a free 7-day trial. But if you do like our options, we have the full packages with many different options with lectures, study plans, study guides, and flashcards. And now we have Affirm, which is a great option, especially with the holidays coming up. If you want to split up your payments from 3, 6, and 12 months, that's a great option to help pay for some of these packages as y'all prepare to take the NCLEX and have some study guides throughout the holiday process. So, great thing for you guys to check into if you haven't bought stuff already. I also ask for it for Christmas if you want. That would be a great thing to do too. Answer is option 2. Clean the client's eyes from the outer canthus to the inner canthus before administering eye drops. So the question is asking what would we do to intervene? So what is the client or the nurse doing wrong? We never want to clean the eye from the outside in. That would bring bacteria into the eye. We always want to clean from the inside out, bring everything out of the eye. All the other options are correct ways to put the patient in the correct position, and if it actually didn't get in the eyes. So the only incorrect teaching point here would be option 2. We want to clean from the inside out. But y'all guys did very good on that one. Nice and easy fundamental. Next question. The nurse is preparing to administer insulin to a client. Which of the following actions should the nurse take? Option 1, draw up regular insulin into the syringe first and then NPH insulin second. Option 2, hold the insulin syringe with the non-dominant hand and pinch the periumbilical skin with the dominant hand. Option 3, clean the injection site with an alcohol swab and inject the insulin before the alcohol dries. And option 4, check for blood return before injecting the insulin. Which one do you guys think? Let us know. Lots of good answers, guys. Let us also know how you guys are studying. Which do you like best? Do y'all like the lectures and the reviews? Do y'all like to do the question drill sets? Or what features on the app are y'all using the most? We love to hear the feedback on that as well. Let's see, the correct answer would be option 1. Draw up regular insulin into the syringe first and then NPH. So I always think of the mnemonic RNs, like what we're striving to be, registered nurses. So draw up regular insulin first, then NPH, because we don't want to cross-contaminate the NPH with the regular insulin. So always drop regular insulin first. The other choices are, how would I say, without being, they're not the best practice. That's what I would say. We never want to aspirate with a sub-Q because that can lead to further problems. Never aspirate a sub-Q injection. And we always want the alcohol to dry down. That's why you wait about 10 to 15 seconds after cleaning the area. We want to have a dry surface. And then it's usually just always easier to inject with your dominant hand. You have better aim, unless you're ambidextrous. Use your dominant hand to inject any sub-Q. So good job, guys. Y'all did great on that one. Next question, question 7. The nurse is teaching parents at a community health fair about scoliosis. Which of the following information should the nurse include? 30 seconds on the clock. Option 1, scoliosis affects only the curvature of the lumbar spine. Option 2, surgery is required to correct scoliosis. Option 3, screening for scoliosis begins in preschool. And option 4, scoliosis can cause unequal shoulder height. So which of the following information should the nurse include? Let's see your answers. Good job, guys. Good. Also, let us know what topics you guys would like for us to cover in our lectures and our question drill sets. Last week when I asked, I saw a lot of cardiac questions. So this week we decided to have cardiac question of the day. So we do listen and read all of you guys' comments of what things that y'all would like to read or go over. So drop it in the chat and we'll try to include that into our next couple of weeks of information. Let's see, I see critical care, OB and peds. I struggled with OB and peds, so yes, totally understand there. Lots of OB. So we'll make sure to see if we could do maternity, OB, peds very soon. Correct answer is option 4. Scoliosis can cause unequal shoulder height. So we are looking for the true statement in this case, and option 4 is the only one that is actually true. Scoliosis doesn't only affect the lumbar spine in option 1, it can affect the hips, it can affect the shoulders, obviously. So there's other things that come into play. Option 2, surgery is not only required to correct scoliosis. You see braces as well to help realign the spine if it's in the spine. So surgery is not your only intervention. And then option 3, screening for scoliosis usually happens in the early adolescent time. Think of like during the time kids go through growth spurts, which is 10 to 12 with girls and 13 to 14 in boys. Obviously it varies in age, but it's not in preschool. That's a little too early for scoliosis screening. So correct answer is option 4. Good job. Last question of the day. The nurse is teaching a client with orthostatic hypotension. Which of the following interventions should the nurse include in the client's plan of care? Select all that apply. So more than one answer. Option 1, perform carotid artery massage. 2, decrease dietary sodium intake. 3, apply graduated compression stockings. 4, implement fluid restriction. And 5, administer fludrocortisone. I'm not the best with saying medications, guys, but I tried with that one, fludrocortisone. Let us know which ones you guys think is the correct answer in the chat. I see a lot of people saying maybe. This one looks a little bit tricky. It's okay. It's a learning experience for everyone. I save the best question for last. I'll give you about 5 more seconds. Remember, it's to select all that apply, so it's going to be more than one answer. Okay, correct answer is only options 3 and 5. So orthostatic hypotension. This is what happens when clients move positions, their blood pressure drops. So we want to look for interventions that will help bring the blood pressure back up. And so in this case, options 3 and 5 would be the only answer choices that are going to help promote blood pressure increasing. So graduated compression stockings reduce pooling of the blood in the legs and help bring the blood back up to the heart, which helps reduce the heart strain. So this is going to help bring the blood pressure up. And also fludrocortisone is a mineral corticoid that mimics aldosterone, and this reduces sodium loss in the urine. So sodium or water follows salt. So if you're holding on to the sodium, you're going to hold on to the water too. And this is going to increase your blood volume and also increase your blood pressure. So we want to give fludrocortisone and apply graduated stockings. The carotid artery massage, this is going to stimulate the vagus nerve, and that's usually done with tachycardic rhythms, not necessarily blood pressure problems. That's going to do with a heart rate problem. Option 2, decrease sodium intake. We actually, like I said, want to increase the sodium intake so it has water follow it and increase the blood volume. So we want to increase or have them have a regular sodium diet as long as they don't also have a hypertensive problem. And then option 4, we want to make sure that they have adequate hydration. Again, fluids makes the heart or the blood pressure stay up, so we want to increase or have an adequate volume or hydration. So options 3 and 5 are the correct answers for today.
Thanks for staying tuned for our greatest hits. Last up will be our highly requested ABG lecture. Drive home all things acidosis and alkalosis with this lecture session coming up next. So today we have a pretty big topic at hand. We're going to be covering our acid-base imbalances with our ABGs or arterial blood gases. So pretty tricky stuff, but we're going to go through it slowly and we're going to get through it together. So let's start at the very basis. So acid-base imbalances are going to be a complication of a condition. They're not a standalone diagnosis by itself. So the acid-base imbalance are going to be going on in the background essentially when something else major is at play to cause it. So these imbalances are typically going to be focused on dysfunction in one of 2 areas. So when we have metabolic imbalances, being metabolic acidosis or metabolic alkalosis, we're going to have kidney problems. And when we have respiratory imbalances, being respiratory acidosis or respiratory alkalosis, we're going to have lung problems or breathing problems. So to understand when we're out of range with our values, we need to understand what our reference ranges are. That way we can spot these imbalances when they do arise. So we're going to talk about 3 things in particular. First is that pH. This is going to tell us, is our blood acidic, is it normal, or is it alkalotic? So I'm going to ask you guys a question. What is the normal pH range? Go ahead and give me a value, and if you only can get 1, no worries, but drop that in the chat, let us know. Again, what's a normal pH range? Testing your knowledge. And right off the bat, I see Shanice got it and Nell 7.35 to 7.45. You guys are totally correct. Hope, Mitch got it, Dell got it, Laura got it. Way to go, you guys. Great job. So yes, our normal pH is between 7.35 and 7.45. A number below that 7.35 would be indicative of acidosis, and a number higher than 7.45 would be indicative of alkalosis. So on the low side, we're acidotic. On the high side, we're alkalotic. Our next number is CO2. So we've learned about carbon dioxide a couple of times through our live. We hit this point really hard in our COPD live, but high levels of carbon dioxide are going to make us acidic or have a low pH because that's the acidotic side. A normal range for CO or carbon dioxide is going to be 35 to 45 millimeters Hague. A great way to remember this is take that normal pH, 7.35 to 7.45, and just drop the 7, and that gives you 35 to 45, which is a great way to remember carbon dioxide levels. Our last point to drive home is our base, our bicarb, that HCO3. So a normal bicarb range is going to be 21 to 28 mil equivalents per liter. High levels of bicarbonate, that's more base, they're going to make us more alkaline or be in a state of alkalosis. So again, pH, carbon dioxide, and our bicarb are our 3 most important values to know. The good news is that the NCLEX now gives you our normal reference ranges, so there's less memorization work on y'all's side. So a little bit about the general principles about these imbalances before we dive in. So acidosis, again, too much acid or a loss of too much bicarb, and alkalosis is too much bicarb or base and a loss of too much acid. So with that in mind, let's dive into the metabolic side. So what are some causes of metabolic acidosis? We're going to switch to our acidosis scale to give you a good visual to go along with this. Again, anything that we put up there, you guys are free to screenshot, take with you. So let's start with metabolic acidosis. So again, we know metabolic means kidneys. Our kidneys are impacted. They're the, problem players here, and acidosis means we either have too much acid, making us acidotic, or we've lost too much bicarb or base, putting us into a state of acidosis. So reasons for too much acid can either be from too much acid production, like an increase in lactic acid. We can see this in our circulation from poor perfusion, or even in cases of carbon monoxide poisoning, or we can also see acidosis from the release of ketones, as in DKA or diabetic ketoacidosis. It can also be as simple as intaking too much acid, like taking too much aspirin, which we know is acetylsalicylic acid. We can also see metabolic acidosis from the impaired excretion of acid. So we're not able to get it off. This can happen in kidney diseases. We just did a live on chronic kidney disease. Check that out if you want more references. Remember, our kidneys are ultimately what decides what's going to be filtered out through the urine and what we're going to hang on to and send back into our blood. So if the kidneys aren't working or if they get backed up, we're going to have a buildup of waste and electrolytes in our blood, including a lot of these really acidic elements, putting us into a state of acidosis. Our last cause of metabolic acidosis are going to be anything that causes us to lose too much base or lose too much bicarb. So problems with excretion, and this can be like excessive diarrhea, when we're losing that bicarb, losing that base, putting us into a higher acidotic state. This can be like diarrhea from C. diff or gastritis or something like that. Alrighty, so switching sides, we're going to stay in the metabolic side, but let's think about alkalosis. So we're going to pull up our alkalosis scale. And again, what are our causes of metabolic alkalosis? So we're switching gears now. We're thinking on the opposite side of the spectrum. It's the same principles as metabolic acidosis, but here we're going to just reverse it. So we know metabolic means, again, our kidneys are affected, and alkalosis means we have too much bicarb, i.e. base, or we've lost too much acid. Reasons for too much bicarb can be as simple as excessive ingestion of bicarbonate, like taking too many antacids. This is pretty much just like straight bicarb tablets, so this can be a cause. These are like Tums, for example. Or we can see large amounts of acid loss put us into metabolic alkalosis. So think about our stomach when we think about too much acid loss. Our stomach is full of acid, so when we have excessive vomiting, or maybe we have excessive suctioning, they're set up to suction via an NG tube. Anything that's consistently pulling acid out of our stomach is going to remove that acid, causing us to be too alkaline. So in the same vein, also think about medications like diuretics and thiazides. So it can cause the excretion of hydrogen in our urine. We know hydrogen is acidic. It's a driver for pH. After all, pH stands for potential of hydrogen. So when we're losing this hydrogen, we're losing our acid, and our pH is getting higher, i.e. more alkaline. Alrighty, so that was a lot. Maybe take a second and we'll take a deep breath, but you guys are doing great so far. So now let's go back to that acid-base table. We're going to look at some clinical features here. So clinical features of metabolic acidosis. Essentially, what does this look like in a clinical setting? What are these clients going to present with? We need to think about things that will cause metabolic acidosis. Let's think back to DKA, or diabetic ketoacidosis. So these clients often present with something called Kussmaul respirations, those really deep, really rapid respirations. They also may have signs of hyperkalemia, which we know we can see cardiac complications from this, like dysrhythmias such as peak T waves. And we also know that diarrhea can be a cause of this, so we can see diarrhea in these clients. Our clinical features of metabolic alkalosis on the flip side, there isn't a whole lot to say about this, but again, it's when we're getting rid of all that stomach acid, clients set up to excessive NG tube suction or who are vomiting too much, are getting off too much acid, they're going to have metabolic alkalosis, and in general, this client is going to feel very unwell. So now we're going to jump into compensation, and this is kind of where things get nitty-gritty. So if you need to take a little stretch, take a little breath, let's do that. But we know what's going wrong. We know our clinical features. Now, how does the body compensate for this? How do they make up for it? So let's talk about metabolic acidosis first. So we're on that low pH side, that acidotic side. And remember, metabolic means kidneys. So remember, we have that low pH and we have that low bicarb. So in response, the lungs are going to kick in to help out their friends, the kidneys. The kidneys are not really working to full capacity here, so our friend, the lungs, need to jump in and help. In response, the lungs are going to increase their rate of breathing. So we have an increased respiratory rate, so the lungs can blow off more of that CO2, which we know is acidic. So when we're blowing off that CO2, our pH is going to rise because we're getting rid of acid, making us more alkaline. So our lungs help by blowing off that CO2. They increase the respiration rate. We may even be hyperventilating here. Now, compensation for metabolic alkalosis, let's think of everything in reverse. It's the opposite. Here we have a high pH and low acid. We are more alkaline here. So in response, the lungs are going to slow down to help those kidneys out. We're going to see a decreased respiratory rate because we're holding on to that CO2 because it's acidic, bringing our pH down back to a normal range out of a state of alkalosis. This is going to help lower our pH, and our bicarb will lower as well. Alrighty, so quick knowledge check. Just make sure everyone is staying up to date. So knowledge check, will breathing increase or decrease in metabolic acidosis? So a client in metabolic acidosis, will the lungs compensate by increasing their rate of breathing or decreasing their rate of breathing? You have a 50-50 shot of getting this one right. All right, take a second, mull it over, think about it. But metabolic acidosis, are those lungs increasing the rate of breathing or decreasing the rate of breathing? And a big hint here is think about what they're breathing out, what they're getting rid of. What do we have too much of in metabolic acidosis? Alrighty, I see a couple answers coming in, and we may be a little bit torn here, but we are increasing our rate of breathing in metabolic acidosis as a compensatory mechanism to breathe off excess CO2, meaning we're going to increase our pH, taking us out of acidosis, hopefully into that normal range of 7.35 to 7.45. So increasing was our correct option. Way to go, you guys. Looks like a lot of you got that correct, but that was a really tricky one. So no worries if you're still a little bit confused. Let's go over our nursing interventions, and this may really help to drive this point home. So remember, metabolic acidosis and metabolic alkalosis are never the primary diagnosis, but rather a symptom of another condition. So obviously, nursing interventions, the first and foremost thing we should do is treat the underlying cause. But there are also some additional supportive measures that we should know to take as nurses. So in general, we need to make sure we're monitoring our ABGs, we're administering IV fluids, and giving electrolyte replacement as needed. For metabolic acidosis specifically, we need to monitor our lab values, especially that lactic acid. We know we have elevated lactic acid in sepsis, so we definitely need to watch how this is trending. And again, it's an acid, so it's going to continue to make us more acidotic. We also need to replace fluids and electrolytes as needed and give certain medications. So we know that diarrhea can cause metabolic acidosis because we're getting rid of all that bicarb in the stool, so we may need to give an anti-diarrheal like a Lamodal, and we may even need to give some IV bicarb to the client to help get them more alkaline and out of a state of acidosis. On the flip side, for metabolic alkalosis, it's the same basic principles, just in reverse. So we're, of course, treating the underlying condition. We are replacing fluids and electrolytes as needed, and we're going to give necessary medication. So a big cause of metabolic alkalosis is vomiting. So we may give an antiemetic like azofran, Phenergan. We also want to make sure we're stopping the use of diuretics so that our kidneys start sending that acidic hydrogen back into our blood instead of excreting it through the urine. So we're stopping our diuretics because we want to stop the loss of that hydrogen. It's acidic and we can hold on to it to take us out of a state of metabolic alkalosis. And we also want to make sure we're avoiding suctioning. Again, suctioning is going to remove the acid in our stomach if it's like set up to an NG tube. When we remove the acid from our stomach, it makes us more alkaline because we're getting rid of acid. So we would want to stop this suction. Alrighty, that was a lot, but you guys did so great. Way to go. I see a lot of people interacting in the chat, so happy to have you all here. If you are just joining, we're going to do a quick summary on the metabolic acidosis and alkalosis that we just did. We're going to jump to our flow chart as a little refresher before we move on to the respiratory side. So again, metabolic acidosis, let's pull up our cute little flow chart, and this is going to be a great visual for you all. Metabolic acidosis means low pH, so we have too much acid and not enough bicarb. Our kidneys first try to compensate themselves, but when they can't quite cut it, they're going to call in backup from their friend, the lungs. The lungs are going to breathe faster to blow off that excess CO2, which is an acid. When the pH returns to normal, then we will be considered fully compensated, but we will have a low CO2 because we blew it all off, which means we're going to end up in something called secondary respiratory alkalosis. Kind of confusing, but you see how this is such a tender balance. It can flip from one side to the other relatively quickly. On the other side, we have metabolic alkalosis. Here we have a high pH. What happens here is we have low hydrogen or low acid and too much bicarb. Our kidneys first try to compensate, but when they can't cut it, they're going to call in for backup from our lungs. Our lungs are going to breathe slower to help retain and hold on to that CO2, which is an acid. And by holding on to that, we're going to see our pH decrease, go back down towards a more acidic side, hopefully return to normal. When the pH is normal, we would consider this to be compensated, but we're still going to have a higher CO2 because we're retaining it. And this is going to put us into something called secondary respiratory acidosis. So you see how the compensatory mechanisms can sometimes go too far in either direction. Alrighty, so that was a lot of information, but you guys are crushing it so far. So let's go ahead and move on to the respiratory side. So we just covered metabolic, which means our kidneys are, having a little trouble. Now let's switch to our respiratory side. All right, we're going to pull up our acid-base table again. All right, and we've talked about respiratory drive a lot on our COPD live session. But just a quick refresher, if you want more explanation, go ahead and check that out on our YouTube page. But remember, we breathe in oxygen. I think we all know that at this point. This oxygen makes its way through our upper and our lower respiratory system, where that gas exchange eventually happens in the alveoli of our lungs. So our blood here at the alveoli is going to offload that CO2, and it's going to pick up some fresh oxygen at the alveoli. The CO2 is really where all of this imbalance starts in the blood. So in respiratory acidosis, we're going to think about hypoventilating, breathing slowly, and this is going to cause a buildup of that CO2, which is acidic, and it makes our blood more acidic, putting us into a state of acidosis, which means we have a lower pH. On the other hand, in respiratory alkalosis, here these clients are typically hyperventilating. They're breathing too fast. They're blowing off all that acidic CO2. Therefore, they're getting rid of too much acid, which is going to increase our pH level to a more alkalotic state due to that lack of acid. So quick refresher here for respiratory. We are hypoventilating, means we're going to be put into respiratory acidosis. If we're hyperventilating, we're more likely to be in respiratory alkalosis. So let's go over some causes here. What are some causes of respiratory acidosis? So let's talk about this. We just need to really tie everything in to that hypoventilation that we just brushed on. Let's start with some acute causes. So first, our client can have an airway obstruction, super scary. So along the lines of choking or aspiration, they're hypoventilating because they're not able to breathe. We can also see chemical respiratory depression, so anything along the lines of an opioid overdose, maybe alcohol intoxication, even magnesium toxicity can cause respiratory depression. And lastly would be respiratory muscle weakness. So we can tie this into the pathology of like Guillain-Barré syndrome or a spinal cord injury. Remember that the part of our brain that controls our breathing is in the brainstem. So injury to the cervical spine area can really impact our breathing centers and what control that. Those are the acute causes. So the chronic side that cause respiratory acidosis, things here are going to be like COPD, that chronic obstructive pulmonary disease. We talked a lot about how clients who have COPD, their respiratory drive is triggered by oxygen instead of CO2, which would be normal. So the body essentially becomes accustomed to these rising levels of CO2 and it blunts the respiratory system response. So again, we have our acute causes of like airway obstruction, chemical respiratory depression, any kind of respiratory muscle weakness, and then we have our chronic conditions being COPD. Alrighty, so flipping the script, other side of the mountain here, what are some causes of respiratory alkalosis? So moving on to alkalosis, we remember that respiratory alkalosis, these clients are going to be hyperventilating. They're breathing too fast, breathing off too much CO2, getting rid of too much acid, meaning they're going to be alkalotic. So let's talk about things that cause hyperventilating. Panic attacks and anxiety attacks, as well as some pulmonary conditions, like think about pneumonia, maybe an asthma attack, things like a pulmonary embolism or a PE. All of these things cause impaired gas exchange, either from obstruction in the airway or lungs or problem breathing. Other causes can include things like fever, high altitudes, and a client on mechanical ventilation who's on improper ventilator settings. Alrighty, so I see pain as another example. Great job, you totally nailed it. So clinical features, what are we going to see these clients in a clinical setting? What do they present with? What do they look like? So let's start again with respiratory acidosis. What do these clients look like? So beyond just decreased respirations and that hypoventilation, these clients are going to show some neurological manifestations of that buildup of CO2, so that high CO2 level in the blood and that low oxygen or hypoxia. So think about things that result from not enough oxygen to the brain. This can be things like confusion, lethargy, drowsiness, irritability, and headache. As this progresses, it can progress all the way into late signs like seizures and even the potential to progress to a coma. So some pretty serious things here. On the flip side, our clinical signs to go to respiratory alkalosis. What is this going to look like in these clients? So in respiratory alkalosis, remember we have that low CO2, so we don't have enough acid, and we have that fast respiratory rate, so we're hyperventilating here. This can cause things like lightheadedness, dizziness, confusion, we can see tachycardia, and due to the other process that's happening in the background that's causing this, our client can also see hypocalcemia. We know hypocalcemia causes our textbook signs like that numbness, tingling, especially around the hands and the mouth. And the same with respiratory acidosis. The late findings here in respiratory alkalosis, it can even progress to seizures and coma. So it's so important to identify these findings early and intervene so it doesn't escalate to seizures or coma, which again are so dangerous. Alrighty, so now again, let's get into the nitty-gritty. Let's talk about the compensation. I think this is the trickiest part to get, but once you understand it, you see how it all fits together and it's going to make a lot more sense. So how do we compensate on a respiratory side? So just how in metabolic acidosis and alkalosis, our lungs stepped in to compensate for our kidneys, it's the reverse here. Now we're in respiratory acidosis and respiratory alkalosis, so our kidneys are going to jump in, help out their friend the lungs, and we're going to compensate via the kidneys. Alrighty. So respiratory acidosis, we know already we have too much acid from the buildup of that CO2. So our kidneys, how are they going to help? How are they going to help out their friends, the lungs? They're going to jump in and secrete hydrogen in the urine, which we know hydrogen is an acid, it's acidic. So by excreting it and getting it off, we're going to raise our pH, get less acid, which is going to bring us back up, hopefully into a normal range, but we're going to trend higher. And also our kidneys are going to help to reabsorb or send back that bicarb into our blood or our bloodstream. We know that bicarb is a base, so this also helps to raise our pH. Now on the flip side, in respiratory alkalosis, we know we have those low levels of CO2, which is an acid, which is why we're alkalotic. So what we need to do is increase the amount of our acid in our system to be able to lower our pH out of alkalosis. So what our kidneys do to help is they reabsorb hydrogen and send hydrogen back into the blood because it's acidic. When we have that more acid in our blood, it brings down the pH out of alkalosis. We also are going to reduce the amount of bicarb we're producing, which is base, and these together, paired together, are going to help to bring our pH back down to a normal level. Again, we're aiming for that 7.35 to 7.45. Alrighty, so quick knowledge check. Make sure you guys are sticking with me. I know this is difficult stuff. So will hydrogen concentration go up or down in respiratory alkalosis? So essentially, will it increase or decrease? So as a compensation for respiratory alkalosis, will the body compensate by increasing or decreasing our hydrogen concentration? So think about respiratory alkalosis. We're alkalotic, we have too much base and not enough acid. We know that hydrogen is acidic. So to compensate, will the body compensate for being alkalotic by increasing acid or decreasing acid? That was tricky, and I think a lot of it's also in how I phrased it, so I didn't mean to confuse anyone, but essentially when the body is in a state of respiratory alkalosis, I asked you guys about compensating. How are we compensated here? The body compensates by trying to increase our hydrogen because hydrogen is acidic, which will offset the alkalosis. So increase was our correct answer, but that was a tricky one. So let's hop to our nursing interventions, which I think really help to kind of drive home what's going on in the body. So remember that this state of alkalosis or acidosis is never the primary diagnosis, but rather it's the symptoms or the pitfalls of another condition. So obviously, first and foremost, we need to treat the underlying cause. But there are some essential practices that we always need to be aware of as nurses. We want to make sure we're monitoring our ABGs so we can know if we're trending in the right direction. We need to give IV fluids and replace electrolytes as needed. For respiratory acidosis in particular, we need to work on improving our airway and our breathing because again, these clients are hypoventilating. So we can do this by supportive measures. We're going to raise the head of the bed. We're going to suction if the client has any secretions. We can apply supplemental oxygen, maybe through a nasal cannula, maybe something more. And we can also give medications to treat that underlying condition. So we said there can be chemical respiratory depression, maybe from something like opioid misuse. We can give a Narcan to treat for this. If this respiratory depression results from magnesium toxicity, we can give the antidote of calcium gluconate to help with this. Unfortunately, if that hypoventilation does progress and we're not able to fix it with chemical interventions, we do need to be ready to intubate the client if that is needed. Alkalosis. So respiratory alkalosis, we need to work also on improving our airway and our breathing, but in a different way than respiratory acidosis because in alkalosis, we are hyperventilating. Remember, causes here can be like anxiety attacks, pain, fever can even cause this. So we may need to apply that supplemental oxygen and we may need to give medication. So if we're having an anxiety attack or a panic attack, a common medication we would give would be like a benzodiazepine or like a lorazepam. And we also want to encourage slow, deep breathing, calming them down, decreasing that rate of ventilation, and maintaining a calm atmosphere. Decreasing stimuli may also help with this. Alrighty, so we're going to hop back to that flow chart. Again, this is kind of a great home base for us to tie it all together. So in summary, to summarize the respiratory side of things, just like we did with the metabolic side of things, in respiratory acidosis, we have a low pH. This happens from hypoventilating and holding on to too much of that acidic CO2 because we're not blowing enough off. Our kidneys compensate, but kidneys compensate very slower. When the lungs compensate, they're a lot quicker. Our kidneys are more of a delayed response. So our kidneys are going to do their best, but they're going to increase elimination of hydrogen to help raise the pH of our blood and get rid of some of that acid to take us out of acidosis. They're also going to hold on and retain that bicarb to hold on to more base and thus help raise our pH. But again, this happens pretty slowly. The kidneys work a little bit slower than our lungs things do. So this client may need additional support like airway and breathing support, and we may even need to push some IV bicarb just to help out a little bit in the meantime. All right, on the flip side, let's switch to respiratory alkalosis. So here we know we have a high pH, here we are hyperventilating, and we have low CO2. So we're breathing too fast, we're breathing off all of that acidic CO2, putting us into a state of respiratory alkalosis. So again, the kidneys compensate. They're trying to do us a solid, but they do it pretty slowly. So it's gonna be delayed. Our kidneys are going to hold on to hydrogen in the urine, which we know is an acid. They hold on to this acid, which brings down our pH, takes us out of alkalosis. They're also going to lower their bicarb production, and these two things together will work to lower our pH. But again, it's happening pretty slowly. The kidneys, I guess, live on island time, so we need to make sure we're providing supportive measures like encouraging the client to breathe slower if they're hyperventilating, giving a medication to treat a panic attack or an anxiety attack that could be triggering this, or if this client is on mechanical ventilation, we need to go look at that ventilator and maybe decrease the ventilator settings. This may be ventilator-induced respiratory alkalosis. Alrighty, so that sums up the bulk of our lecture content. We talked all about the respiratory side, the metabolic side. Now let's go ahead and talk about how we can be presented with a set of lab values. How are we expected to tell these apart? Alrighty, so let's pull up our Rome table, or our Rome slide. So we're not talking about the city in Italy, unfortunately, but we're talking about our trick to be able to differentiate these states of metabolic or respiratory acidosis and alkalosis. So there's a lot of different ways to do this. I know a lot of schools teach different things. Honestly, my best advice to you is to look a little bit into all the different ways to do this and pick the one that works best for you. This is the one that I particularly like, but you may be different. All right, and again, a great time to take a screenshot or take this one with you. But ROME stands for respiratory opposite, metabolic equal. So what this means is we know we can decipher if it's acidosis or alkalosis. That one's pretty easy. We just take a look at that pH. Is it between 7.35 and 7.45? Then we know it's normal. If it's higher than 7.45, we know we're in alkalosis. And if it's lower than 7.35, we know we're in acidosis. So there off the bat, we've at least checked off one thing. Next, we need to be able to figure out, is this respiratory or is it metabolic? And the way we do this is by using the ROME trick. So respiratory opposite means our pH and our carbon dioxide are going to trend in different directions. So we know it's respiratory if, for instance, our pH goes up, it means carbon dioxide will go down, and vice versa. If pH is going down, our carbon dioxide will be going up. Respiratory works opposite. Metabolic works equal. So this case, it involves our pH as well as our bicarb. So if our pH is increasing, we're going to go the same direction with our bicarb. Bicarb will also increase. If our pH is decreasing, our bicarb will decrease. So respiratory opposite, metabolic equal. The last point to drive home, we figured out if it's acidosis or alkalosis, we figured out if it's metabolic or respiratory. How do we know if the body has finished compensating or if it's still trying to compensate? This is where uncompensated and compensated part comes in. So if the pH is still abnormal, we know it's uncompensated because the body has not been able to return to a normal range. Whereas if we have a compensated version, it means our pH has been able to return to a normal pH level. In uncompensated, because we're still abnormal, we may have a normal carbon dioxide or bicarb, whereas in compensated, the body has worked to compensate to get that pH back into a normal range, and because of this, our carbon dioxide or bicarb may still be a little bit out of whack. That's just part of the compensatory mechanism. Alrighty, so we know our trick. Screenshot this, write this down, take it with you, and we're going to use it to answer our 3 questions today. So let's go ahead and jump to question number 1. Alrighty, and another reminder, we are going to give you guys the lab results. The NCLEX gives you normal reference ranges. Okay, so read through this. I'm going to give you a few seconds to go ahead and think it over in your brain, put to use what we've worked today, use it as a lens, and we'll go through this one together. These are tricky and intimidating at the beginning, but I think once you get the hang of it, they're actually kind of fun. They're like a puzzle. All right, I see lots of answers coming in. Great job, you guys. We have some smart cookies in the bunch. Alrighty, so in this case, let's look at our values. The first and easiest place to start with is just that pH. So we know normal 7.35 to 7.45. We're at 7.28. So is that high or is that low? That's going to be low, which means this is a state of acidosis. Okay, part 1 of 3, check, we're done, correct. The next part, is it respiratory or is it metabolic? So what we would look at here is our carbon dioxide and our bicarb levels. So we know our pH is going down. Our CO2, supposed to be 35 to 45, is 55. So this means it's high. So our CO2 is increasing. What about that bicarb? Bicarb is 23, which is within the 21 to 28 normal range. Okay, we're not worried about that one. But if our pH is going down, but our carbon dioxide is increasing, remember it's respiratory opposite. These are trending in opposite directions, therefore we know it's respiratory. So far we have respiratory acidosis. Now I'm going to add one more thing to this. Is this compensated or is it uncompensated? Well, in this case, we still have the pH is 7.28. So is that back within our normal range of 7.35 to 7.45? No, it's not. Therefore, it's not been fully compensated. So we would call it uncompensated respiratory acidosis. But I don't think that asked you if it was compensated or uncompensated or not. I think it just asked you for respiratory acidosis. So option 3 was also our correct option. But most of you guys got that right. So way to go, you guys. All righty. Question number 2. I'll give you guys some time to do this on your own. Let us know what you think, and we'll walk through it at the end as well. But the first one was warm up, even though you all did so well. And now let's see if you guys can get this. So remember, we start with our pH, figure out if it's acidotic or alkalotic. We move on to Rome, is it respiratory or metabolic? And then let's figure out if it's compensated or uncompensated. Whew. This is a long live, so thank you so much for hanging in there with me. All right, so I see lots of answers coming in. Let me check the chats. Okay. And I see most of you think it's respiratory, but it looks like we have a little bit of different answers on whether it's alkalosis or acidosis. Alrighty, so let's go through it. We're starting with our pH per usual. So 7.48. That's out of range, just slightly. Is it high or low? That's going to be high, bless you, which means it's alkalosis. So if we're alkalotic, okay, step 1 of 3, check. Give yourself a pat on the back. We know we have that. So we're in a state of alkalosis because our pH is high. Now let's move on to that bicarb and that carbon dioxide. So our carbon dioxide is 30. This is a little on the low side. Normal range is 35 to 45. So our carbon dioxide is going down. What about that bicarb? We have bicarb as 24. This is normal within range. And so in this case, if we, again, respiratory is opposite, metabolic is equal, our pH is going up, but our carbon dioxide is going down, that's opposite, meaning we know it's respiratory. Okay, step 2 of 3 complete. Now we know it's option 4 at this point. That was our correct option. But is it compensated or is it uncompensated? So first thing to look at, is that pH back within normal range? No, it's not. It's 7.48. It's still high, but our bicarb is normal. So we know this is uncompensated respiratory alkalosis. Way to go, you guys. All right, question number 3. I'm going to let you guys loose on that one. Do it on your own. I know you can do it. I prepared you well. Drop those answers in the chat. Remember, start with pH, then we go to Rome, is it respiratory or metabolic, and then we see if it is compensated or uncompensated. Alrighty, I'll give you a few more seconds. Again, do your Rome trick, draw your arrows, do your decimals, however it works for you. I know there's a lot of different ways that we can do ABGs. The trick is just finding the way that works best for you. All right, I see a couple of answers coming in. Oh, I see some good ones. Way to go, you guys. Proud of you. Alrighty, so let's walk through this one. First things first, what's the pH? It's 7.37. Now that's normal. It's between 7.35 and 7.45. So hey, normally we figure out pH first, but we know it's compensated. In this case, it's normal, but it's still on the low end of normal. So keep that in mind. If you want to draw a little down arrow in parentheses, that may help you out. Now let's look at our carbon dioxide and our bicarb. So these are both low. Carbon dioxide is 33, normal range is 35 to 45, and our bicarb is 20, our normal range starts at 21. So they're both slightly low. In this case, remember our Rome trick, our pH, even though it's still within normal range, is on the low side. So we can give that a down arrow, so to speak. Now respiratory is opposite, but carbon dioxide is also down. So we know it's not respiratory, but our bicarb is low as well. So metabolic equal, they're both trending downwards. In this case, we know it is metabolic. So we know it's metabolic acidosis, and because our pH has been compensated for, therefore it's returned to a normal range, it's compensated metabolic acidosis, which would be option number 1. So way to go, you guys. You did so well today. Reminder, we're back on Wednesday and Thursday with question drills. Wednesday is an infection question drill. Thursday, we're going to be covering developmental milestones. Let's hop to a quick little QBank slide. Again, here's a look into our UWorld product. For anyone that has already purchased or is thinking about purchasing, this is our QBank, so you can get a little look at it now. These are the subjects and the systems that you should select in order to get more questions that include those like acid-base imbalances and ABG, so you can test out some of your knowledge that you learned today. So challenge yourself, get a little more practice in. This QBank slide is just telling you exactly how to do that. Thank you so much for watching today. We hope you learned something new. I'll see you guys soon.